So hi everyone, let's start today's topic. Today's topic is ABPA, that is Allergic Bronchopulmonary Aspergillosis. So what is ABPA? It is an pulmonary infection, or it is an fungal asthma due to the hypersensitivity reaction against the antigen of the Aspergillus fumigatus mainly. Okay, so Aspergillus fumigatus, as we know, it is having hyphae which are acutely angled and are having septate hyphae. Okay, we will learn in detail about Aspergillus fumigatus later on, but here we have to know that mainly caused by the Aspergillus fumigatus, ABPA. Now, how a patient will present of ABPA patient, how will the patient will present? Actually, the patient typically have the history of bronchial asthma or cystic fibrosis, mainly the bronchial asthma. Patient will have the recurrent or the treatment resistant asthma. Asthmatic patient will present again and again. So this history is very important. Okay, patient will already have the bronchial asthma or cystic fibrosis, and then what will happen? The patient is allergic to the Aspergillus fumigatus. So in this patient, what will happen? There is a colonization. Okay, so there will be colonization of the airway by the Aspergillus fumigatus. Okay, what colonization will lead to? Colonization will lead to the formation of mucus plug. Okay, mucus plug formation will occur, and this mucus plug will contain the hyphae of the fungus, and this mucus plug will consequently lead to the mucoid impaction of the airways and plugging of the airway, and this will lead to the dilatation and obstruction of the airways and will further lead to the bronchial wall inflammation. Okay, let's see what happened. That a patient is having history of bronchial asthma or cystic fibrosis. Okay, and after that he again and again present with the bronchial asthma, again an asthmatic attack. Then we should think about the that patient may have ABPA, because patient will have have the colonization of the airway. Colonization will lead to the mucus plugging due to the deposition of the hyphae of the fungus, and this will lead to the plugging of the airways, block of the airways, plugging of the airways, and this finally lead to the bronchial wall inflammation. Okay, now this inflammation or the hypersensitivity reaction which are present in the ABPA, these are type 1 and type 3. Okay, so when type 1 hypersensitivity reaction is present here, so patient will have increased IgE level, and there will be T helper 2 mediated eosinophilia, peripheral eosinophilia will be there. Okay, and patient also having the type 3 reaction and antigen antibody complex reaction, immune complex reactions, hypersensitive reactions. So patient will have the precipitin will be present, mainly the IgG type or IgE type. Okay, so patient have the hypersensitive reaction, bronchial wall inflammation will occur, having type 1 and type 3 hypersensitivity reactions, and finally this inflammation will lead to the wall damage and leads to the bronchiotasis. Okay, and one point we have to keep in mind, bronchiotasis is mainly, it is central in nature. Okay, it is central in location. It is proximal, central, cylindrical, and mainly the upper lobe is involved here. Okay, upper lobe is involved here. So colonization of the fungus will occur. Colonization will lead to the mucus plug formation, lead to the plugging, and finally plugging will lead to the bronchial wall inflammation. Inflammation will lead to the wall damage, and bronchiectasis will occur. And in the late stage, very late in the stage, it may convert into the fibrosis, mainly the upper lobe fibrosis. Okay, in the last stage. Okay, so one term is there that this is the, I will teach you later on. This plugging of the mucus is typically termed as a brownish mucoid plug. Okay, brownish color, mucus will expectorate by the expectoration occur by the patient. So brownish mucoid plug will be there. Okay. So now again just a revision how the patient will present. Patient with the recurrent asthma will be there. Patient will be having the fever, cough, and the expectoration, that is thick brownish expectoration. And when we will suspect that patient may have the ABPA, then on examination patient will be having peripheral eosinophilia. Why the patient will be having peripheral eosinophilia? Because there is a type 1 hypersensitivity reactions. Okay, usually more than 500 will be the number, and IgE, total IgE level will also be increased, and that will be the more than 1000 international rate per ml. Okay, so this will occur, and when we will do the chest X of the patient will be having fleeting opacity. So what do you understand by the fleeting opacity? Fleeting opacity means migratory in nature, means let's see, we have done the X-ray of the patient 1 week or 2 week ago, and when we repeat the X-ray of the patient, that let's see, the opacities will present in the upper lobe, then the patient will come and some other area opacity will be present, and when we will again repeat after 2 week or some other area will be involved. So these opacities are fleeting time, migratory in nature. These are again typical of ABPA. And one term is there, that is glowed finger. Not one, there are various name terms which are used here, like tram track appearance or ring shadows, and the main is glowed finger pains. What is glowed finger pains? That is, I told you that mucus plugging is occur. Mucus plugging, due to the mucus plugging, like let's assume that this is the our right lung, this is the left lung, and this is our airway. So these are the main bronchus, and these divided into bronchioles and further on. So this is the airway. So what will there will be the mucus plugging now. So there will be mucus plugging will be here, mucus plugging will be here, mucus plugging will be here, and so this will appear like a glowed finger pains. Okay, just due to the mucus infection of the bronchioles or the airways. Okay, and one typical finding on the HRCT is again the central bronchiectasis, which we have already seen how the central bronchiectasis occur, and this is cylindrical in shape. Okay, so it is very simple. When we understand the presentation or the pathology of the fungus, how the fungus will how the patient is allergic to the Aspergillus fumigatus, and then inflammation occur, then the wall damage occur, then finally the fibrosis occur, and the inflammation in the form of type 1 and type 3 hypersensitivity reaction, peripheral eosinophilia will occur, IgE will be raised, serum precipitin against the antigen of the Aspergillus fumigatus will be present, and chest X-ray will show the fleeting opacity, HRCT will show the central bronchiectasis. All these features basically comes under a diagnostic criteria, and this is the named diagnostic criteria. This is the Rosenberg-Peterson criteria. Okay, and this criteria is called as Rosenberg-Peterson criteria. Simply if I understand. Okay, so now let's come under the treatment. Treatment is just simply, there is an inflammation, we have to give anti-inflammatory, that is steroid. It is usually given for the 12 week or the 3 months. Okay, and we can because it is having the raised IgE level, total IgE level is usually more than 1000, so we will give the IgE antagonist, that is omalizumab, and the antifungal itraconazole is effective, usually given 200 milligram BD for about the 16 week, and when conservative management is this is the airway clearance by the normal saline or the salbutamol. Airway should be cleared because there is a mucoid infection is there. Okay, So treatment is very simple, but we have to identify, we have to always suspect ABPA in a patient of bronchial asthma who is treatment resistant and present again and again with asthmatic attack, and there are fleeting opacity and central bronchiectasis is there, or so it's very, we can say it is very simple also, but very important also, and we should keep in mind regarding ABPA. Regarding Aspergillus fumigatus and other eosinophilic pneumonias, we will study later on. Okay, thank you for today. Any doubt or anything, please let me in the comment. Thank you.